Yeah, no, great. Thanks, Amanda. Anna, to you. Can you tell us a little bit about the new laws in New South Wales that protect people from psychosocial hazards in the workplace? And do you think they might help people who are in a similar situation? What do you think?
Yeah, thank you for telling us the story, because I think it's really important to set that context as well. And I guess in terms of creating a mentally healthy workplace, it takes an integrated approach. And what the literature suggests is that, you need to take a preventative approach from a workplace perspective. So, ensuring that the workplace is designed in the right way to support the individual workers. Then you promote the positives as well. So making sure you have the right culture in place. So leadership support, everyone's got the training to enable the right platform for a mentally healthy workplace. And then the third pillar, or the third approach, is around supporting those who are unwell, who are, experiencing the signs and symptoms of, say, mental ill health. And so having these integrated approach really will create the right platform for a thriving or mentally healthy workplace. Where the legislation comes into it is around the prevention piece. So in October last year in New South Wales, we adopted the amended regulation. So some context around that, so that you might have heard about the Boland Review. So that was initiated in 2018. So within, I guess, work health and safety laws, you might have heard about the model work health and safety laws, and that is set as the model law, but each individual regulator needs to be able to consider that and adopt that based on this harmonisation of work health and safety. And so in New South Wales, we adopted that in last year. And basically, the amended regulation, or the amended model regulation, was to ensure that there is consistency in terms of applying the right approach to creating the right workplace systems and the frameworks to protect workers. And so that was, I guess, the history around the regulation. How that works in practice is what we're working towards now. So in the regulation, it talks about psychosocial hazards, it defines what it is, and pretty much in that space, it's about anything in the workplace design that can lead to physical or psychological harm. So it's general enough, and we understand that psychosocial hazards, you have your common ones around, say, role clarity or poor leadership support, but there's other factors as well. So, if you're going through change, but it's not managed well, then we understand these as factors that can have an impact on the individual's mental health. It also defines what is psychosocial risk as well, so the likelihood of it. But the most important part is around one part of the I guess, the clause that describes the control measures. So that's a very, I guess, technical jargon term, but really what it considers is the strategies that needs to happen in place. But it steps out about how do you go about making sure that the right strategies are put in place. So you need to ensure, you consider the frequency, the severity of the exposure of the hazards, and then talks through about, from a, design of work, looking at the job demands, how it impacts on the individual. So there's many, I guess, considerations that you need to kind of go through as a PCBU, or the person conducting the business or undertaking. But the most important piece is around the consultation piece as well. So we were talking about this earlier on, where as an individual, you need to feel safe enough to raise and talk about, what are some of the workplace factors that might have a potential to, be triggering or cause harm. But it also now puts, I guess, the onus on the workplace. And it's always had that through the consultation process, but it's heavily emphasized that you need to be able to ask your workers through this consultation process about the work that you're doing. Is there anything that can be changed or redesigned so that it is safe for you and not, cause you harm? And that process needs to be monitored and reviewed on a regular basis as well, because we know that risk change, depending on the context, depends on what's going on for the individual, but also like the broader aspect about the workplace itself. So I'm confident that the regulation is definitely one step towards better for workplaces, to create a better workplace environment. But I think it should stop there as well. Yeah.
Great, thanks for running us through all that. And Sharon, I'm interested to hear whether the organisations that you work with are, you know, set up to support people with mental health challenges. And yeah, do you think they can help us find and stay in work? Those of us with mental health challenges.
Yeah, sure. Well, just to give perspective, we have about 100 members. So they're cross-sector organisations, you know, largely medium, small businesses, but we also have government departments, universities, non-profits, sole providers, so service providers. But when you think about it, I was looking at the stats. 2022, there were 784,000 small businesses operating just in New South Wales. So we have 100. So when you think about it, we have such a small sample of what's happening out there. And I have to say the members that we have are already there. They're already passionate. They're committed. They're extremely resourceful in terms of how they're supporting workplace wellbeing themselves. So we have a group of committed organisations. What we need to try and tap into is, you know, those other organisations out there. And we know that a lot of small businesses don't have HR teams. They don't have wellbeing teams like some of the big corporates. They're the sort of organisations that could really use a lot of help, and they're the people that we're targeting. I think, you know, in terms of some of the work we're doing, we are connecting with industry, we connect with peak bodies. So we hear a bit of what's happening out there, and I can talk a bit more about that if you're interested. But I think in terms of on the whole, we are seeing a shift happening. There is, you know, the old idea of, and Anna will laugh at this, but wellbeing was providing a fruit bowl. Well, it's not just about providing a fruit bowl these days. It's really around, you know, having real authentic initiatives in the workplace. Like Anna was touching on workplace design. It's bigger than just flexible working. It's a whole range of things Anna talked about. But there's also, you know, now indicators that organisations are using around workplace wellbeing. You know, they have indicators. I'll talk a bit more later about incorporating it into your strategic plans as businesses, employers. There's also, in our forum, we've had a lot of focus in the forums that we run around psychosocial risks, which has been a bit of a focus, but there's also more of a focus on, okay, how do we champion workplace wellbeing? How do we incorporate it strategically into organisations from the top? So it's governance, it's not just led by HR or wellbeing teams. So we're certainly seeing a lot of good practice examples, particularly around this new world that we're all in when we have hybrid working as a new norm. And hybrid working, really, it's how do you connect people? How do you create a sense of wellbeing, belonging? So there's some of the challenges that organisations are grappling. You know, how to bring people together. And we know connection aids mental health. There's a lot of research. If you look out there, there's so much research around the importance of, you know, feeling connected, feeling like you have quality relationships and belonging, and how that prevents that isolation, loneliness. So there's some of the key challenges, I think, in living in this world that we're in, that employers are starting to grapple.
That's great. And it's good that employers are thinking a bit more about this than they were a little while ago. Samina, as a researcher, what advice would you give to someone who might be experiencing a mental health challenge at work right now?
We're seeing that especially this time of year can be particularly stressful for different sectors. For example, the retail sector, now it's really amping up to the holiday business, and customers are strained. They're having a lot of financial considerations they didn't have before. And so we've been hearing from professional groups that they have had difficult experiences at their workplace. So this is a very timely question, especially at this time. We've been seeing from a research standpoint time and time again that seeking help early for emotional problems makes a huge difference. It leads to better outcomes of any treatment approach that might be selected it prevents or, you know, depending on which issues are there, but it can lead to mental health problems not becoming so chronic and not so severe. And it also can help with comorbidities, so maybe health issues that arise from chronic stress, or using substances more, and so on. So my recommendation that I want to give today, or what I want to bring home, and I'm certainly probably preaching to the converted, but is to really think about seeking support from mental health professionals earlier on, not sort of getting trapped in the mindset to think, oh, other people need it more than me. And, you know, if you think about it from a population point of view, that's certainly true. There's always somebody who needs a service more than oneself. But it is important to look after oneself when you notice that the workplace is straining you so more than before, or increasingly so, or for a longer period of time. And so there is a workplace avenue, of course. It's the Employee Assistance Program, and in New South Wales, this is actually a confidential service. So your employer might know how many people have accessed the service, but not who those people are. So it is protected in this way. But if somebody is seeking help just through private avenues alone, we usually recommend making a longer appointment with one's general practitioner, who can establish a mental health care plan. And the GP usually has a pretty good idea which mental health professionals are available in the area and who would be a good fit. And that's quite important to have a treatment professional who sort of establishes a good relationship in this therapeutic sense. So seeking that support from the GP can lay a good groundwork there, foundation. Also in New South Wales, there's the mental health line that can be called 24/7. And there are mental health professionals on the other end of that telephone, and they importantly can also refer to mental health services in your area. And what some people don't know is that you can also put someone forward, so you can speak on behalf of somebody maybe in your family, and you can help them to get referred to community services. There are always the crisis support helplines as well. I think everyone knows, like Lifeline and Beyond Blue, but there are also some that are culturally sensitive, like 13 Yarn for Aboriginal and Torres Strait Islanders. And there are also helplines that are specialized for occupational groups, like Open Arms for veterans, for example. If somebody says, okay, I don't want to talk to anybody, but I want to try something that might help me, but I want to do it on my own, there are also mental health programs that can be accessed online. Good ones are MindSpot and This Way Up. They can be sort of used at home and in a very self-directed manner. And that's usually a really good stepping stone as well, to sort of feel out how, looking at those concepts would work for somebody.
Thank you. And because we have less time today than we thought, how about everyone start thinking about the questions that you might have? Do we have people online as well, Julian?
Yes, we do.
If people online could start thinking about some questions as well. I'll just ask one question now. Looks like someone has a very desperate question that they have to ask. Okay, all right. I do have a question for Anna, actually, and I'm actually really looking forward to hearing how you answer this. So earlier this year, the Australian Workers Union conducted a survey with more than 1,200 workers. And they found that half of the workers had experienced being bullied, harassed, or exposed to conflict or inappropriate behaviour. And we know that psychological injury is the fastest growing workers' compensation claim, according to the AWU. So what can people do to create change in their workplace if they experience bullying, harassment, that type of behaviour?
Yeah, it's a great question. Now, look, we acknowledge that claims numbers are going up, but at the same time, raising awareness gives people the agency to report it as well, to talk about it. So that's a good thing. So we actually want to understand what's the true landscape in this space. And so I think in order for the right measures to be put in place, it's about reporting. We do encourage workers or employees to raise these issues if they experience it in the workplace, and they shouldn't. So they need to report it to their workplace. And that's where I guess we're hoping that the workplace have the right systems in place to manage that and to prevent these I guess incidents or situations from occurring. The regulators are available to respond to situations like that too. So, our inspectors, we've got an inspectorate who responds to issues that's raised to us. We've got the Speak Up app, which is an anonymous app for these kind of reportings as well. And so I feel like raising the issue is definitely the first step, but we also acknowledge how difficult it is to talk about it as well. So the points that you just shared earlier about seeking the supports. And so that's my opinion, is to, seek the right support to help you to raise these concerns. So whether that is support from your peers, support from, EAP, support from families to really talk about it and raise it in the workplace. Yeah.
Thank you. And Amanda, given you have lived experience, how do you feel about that? What do you think people should be doing?
I don't think any of the systems that are on offer work. When I had a psychosis, I went to my GP. And I know everyone's meaning, we're all here because we mean to make it better, right? And I know we're all meaning that, but, I went to my GP. My GP is a brilliant doctor, did not know what to do, put me on so many meds. I put on 10 kilos in 2 weeks. I couldn't get into a psychiatrist for a month. We've got, it's like there's this veneer of a story that everyone's okay because we've got all these systems, but no one knows they exist. If you're in a crisis, it's all on you you've got to go do this, but you're in a crisis, right? I feel like there needs to be a flip around where people whose experience is part of creating the solutions, because it's a really disempowering experience to go through the mental, the doctors are the ones who know everything and you're the listener going, when should I take those meds? It's a quite disempowering experience to go through a mental health crisis. So let's come up with a process that allows for people who've been disempowered to feel more power in the process of transformation of the system. And then we definitely do want to be able to go to our doctors and go to the psychiatrist. We need all of that. But, those systems are always going to be overwhelmed when we have a society that is actively producing mental health crisis, as fast as it makes money, the workplaces, schools, civic institutions, they trade on mental illness, and so how do we we need to go, stop people falling off the cliff. We can't just be ambulance chasers. We need to go upstream, whatever mixed metaphor you want, right? There needs to be a part of our work that's definitely responding to acute crisis. But I spend most of my life not in acute crisis, but I still have a life managing a chronic mental health condition. How can we create an environment where people can manage their chronic mental health condition, which should just be it's fine for me to go to work. Just as it was cool when women started working as well. We could make workplaces work for women who were going to have babies. We just changed the rules. What would it take for us to change the rules across the board so workplaces were not causing so much crisis, so much mental, because the doctors, they'll never be able to, we'll never have enough doctors and enough clinicians and enough therapists. I feel like we need a medical response I'm here in allyship. My doctors have saved my life. I'm in full respect. But then we also need a social response that's so much bigger. That means other voices need to be heard too.
Do either of you, Sharon or Samina, want to add to that, or should we move to questions? Move to questions from the floor. Okay, we have several questions. Okay, you've asked your question first.
My name is Gwen, ex-nurse, ex-mental health NGO worker, ex-care worker. Can I just say that when you go to the GP, yes, they don't know what to do. Okay, the average GP, research has shown that the average GP allows you 11 seconds before they interrupt. You can't access.
They give you a mental health plan, 10 sessions. If you've got an enduring, we prefer the term enduring to chronic. If you have an enduring mental health condition, 10 sessions ain't going to do it. Psychiatrists, if you've lost your job, how can you afford a private psychiatrist? And unless you have a psychotic illness, you can't access a mental health service, or unless you have a psychotic depression. Hate to say it, Julie, but the worst thing you can do for your mental health is to work in a government or a health department. The number of nurses who used to disclose to peer workers that they have a mental health condition because it wasn't safe to do it amongst their peers. EAP, absolutely no use. Anyway, all they think about is where does this fit in to their risk management matrix. So I appreciate everything you're saying that doesn't work. What I would like to see, and I know works, is more peer support services, consumer operated services, the safe havens. We used to run a phone connections that was funded by health. Things like that, that works. Before you get to crisis, these are the people you talk to, because we're not going to medicate you. We're going to see how this works. If we don't think it'll work with you, we will discuss what is the best option. We won't make decisions for you, but we will talk with you about what are your options, what should we pursue, and that's the way we need to be going.
Thanks for your question.
I'm sorry about that.
No, that's okay. Should I get any of the panelists like to make a comment on that one?
Before I came in here about the exact same issues, I said exactly what you've just said, pretty much, didn't I? And yes, we the problem is, as you said, 10 sessions just doesn't cut it. And for a lot of people, affording a GP is the impossible. So for people to go for a standard consultation even, which doesn't cut it because you've got to have a long consultation when you're getting a mental health plan. And for most people with a chronic or complex mental illness, like my daughter has schizophrenia, you're going to a psychologist once a week. So that 10 sessions pretty much runs out. And then you're having to go back and pay to get another, unless you have a healthcare card, which a lot of people don't. So it becomes, it gets to the point where we were talking about the fact that people can't afford healthcare. So then what happens is they get into crisis, they become acute, and then they end up in the hospital system. If they're lucky, that's another story. I can tell you I recently had to wait 12 days for a bed for my daughter. So if you're lucky, you get a hospital bed. So it's this vicious circle that I don't think state and federal governments see the dots that it all actually connects. And the other issue we're finding is we just did a survey, 2,000 people, 50% lived experience, 50% without, and 30% of people with lived experience said their GP discriminates against them because of their mental health. So that's another issue, is that we need more training for GPs. GPs need to understand mental health conditions. I myself found they don't understand antipsychotic drugs. They don't know the side effects. They don't have training on a whole range of complex issues with mental health. So I think, you know, training, education, we found 7 in 10 people said that they have discrimination in their workplace and they won't disclose their mental illness. And that example of healthcare is one of the worst areas, to be frank. Yes, yeah. Absolutely, absolutely. And the National Mental Health Commission in their survey found similar results. So we looked at our results and compared and did a bit of cross analysis. They found the same things. So I think in terms of the system, I mean, my view is that it's pretty broken. And that, you know, if you're lucky enough, we were talking about rural areas, and I've worked in some of those, you know, the Central West, Canamble, places like that. You're lucky to get a service. And if you're lucky, telehealth, for many people, telehealth doesn't cut it. So if you have a complex mental illness, you need to be seen by, in full, your whole body, by a psychiatrist. You need to get them to see the side effects that are happening of the medications. You need to see how you're presenting, what your psychosis looks like. Telehealth for some people works wonderfully, but for others with complex mental illnesses, it doesn't work. Yes, exactly. So I wholeheartedly agree with everything you said. Yeah.
Thanks, Sharon. So who was the other people? Okay, we'll just go here and then we'll come. Maybe the microphone.
Thanks. Sorry, this is a bit of an not quite somewhere between a question and a comment. So with, especially with Anna, you talked about the new regulations, etc. And Amanda, you've spoken about the pathways and the difficulty in following those sort of pathways. So will SafeWork New South Wales look at also, aside from the regulations and training for organisations, look at some of the pathways and outcomes? For example, at the moment, the outcomes, if you are very clearly discriminated against because of mental health or other reasons, you know, there are clear pathways, but those pathways don't amount to systemic change. And that's a really big issue, because many of us who are committed to systemic change might not want to follow the pathways or feel that we have the capacity to follow the pathways if there's not a really significant outcome, because it's just too hard. So where are we at with that?
The intention of the regulation is to look at the design of the workplace. So in order to prevent, take into account, you know, the role, the common risk factors. So for example, let's say PE workers, I think that's a really good example, because that's something that we're looking at. So we've got a strategy that's due to be released sometime in the new year, basically looking at psychological health and safety, and trying to leverage the regulation and help to identify and educate, and so raise awareness, build capability around what does that look like for businesses. And then there's the compliance side of things as well. So in terms of, you know, going out, our inspectors going out to really do these inspections and audits to check whether the right systems are in place and whether there is any, I guess, the bits of the legislations are complied or not. So take into account, I guess, you know, the PE workforce, and, you know, broader to, like, you know, supporting those with lived experience of mental ill health as well. And we, you know, spoke a bit about that. But, well, you know, knowing that we've got these workers or workforce, what are the right control measures, and how do we go about with consulting with the workforce to prevent harm? So, you know, what are some of the safe ways of doing the work so that the workplace have the right structures in place and design the workplace in the right way to prevent harm for these particular niche workforce and individuals who we understand are more, I guess, vulnerable to psychological distress or harm, depending on, you know, what factors they're exposed to. So that's I guess, our next phase. Hopefully that answers your question to, you know, what our journey is in terms of from the release of the regulation last year. It's a 3-year journey that we're hoping to build, raising awareness and building the capability of the workplace, and, you know, strengthening our compliance in that space as well.
Thank you. Thanks for your question and thanks for your answer. I think the library is going to close soonish. So how about we take 2 questions now? We've got one here and then we've got one online. We'll take them both together.
Thank you, Amanda. I've got a question to follow up around safe workspaces. I work at Being and are running the co-designing committees around suicidality and self-harm. I am a consumer lived experience person with 14 years of lived experience in the system. have definitely experienced trauma within the mental health space. I have a lived experience of bipolar and 14 years experience with systemic abuse. And I want to know what safeguards are going to be in place for consumers within the mental health system, within wards in terms of inpatient settings. In terms of my experience in community settings, I was on at a very early age. In terms of my first episode, I was on very heavy meds of olanzapine for 2 years. I was taking this against my will on CTOs. I was not happy, saying I didn't want to be on these drugs, and it was 4 times seeing different registrars saying I don't want to be on these drugs. 4 times I said I don't want to be on these drugs. After the 4 times, 20 kilos heavier, I said I'm not taking them anymore, and they finally changed them. I had eating disorders after eating disorders, and have suffered since. And I believe I wouldn't have developed such intense experiences had I not been forced to take these drugs. So I want to know, I have a multitude of other traumas from those experiences, but in terms of community treatment and forced community treatment, what safeguards are in place for lived experience folk who are on CTOs, not to mention depots, but yeah.
Thank you. Just hold that thought for a moment and I'll read you this second question, which is from online. So this person would really like to hear of any strategies that managers can put in place to ensure a psychologically safe workforce. So it's about strategies that managers can put in place. Is that it? Yeah.
Okay, that's the question about the workplace, because I guess that's the role of the regulator, really about focusing on the workplace itself, and how they can protect their workers. So from a manager's perspective, it's really about creating the right team environment to enable your staff to bring the whole self to work, which means also to share some of their concerns. And so we talk a bit about the differences between psychological safety and psychological health and safety. And so psychological safety is around this shared experience in the team, how safe they feel to talk about issues that affect them without feeling judged, or, there's that risk to sharing the information. And to create that right environment or the culture around it really starts from the leader, the manager, to enable people to share any issues, whether that is to really the managers start from themselves to share their own issues, talk about their day, but also invite their team members to share that, so that there is that sense of trust in the team. And so when things do change and affects their staff member, hopefully the staff member feels safe enough to bring it up with their manager. So I think that's a really key part. And there's training to get the right communication skills, the right framework in place. And I know Black Dog offers training for managers, and so Safe Work, we do provide free training to small to medium-sized businesses to their leaders and managers to enable that for them to create the right environment. So I would say that will be the first thing, because otherwise it's hard for any interventions to be put in place if they're not spoken about.
Thanks so much, Anna. I'm going to ask the other 3 speakers if you'd like to answer question 1, question 2, or say something else, because I hear the announcement for the library to be closed.
I don't know how to answer question 1, but I just want to acknowledge it, is that I think anyone who has had really serious mental health crisis has to live life with a lot of pain, and a lot of people
not recognizing that pain. And I think it's really powerful that you've shared the kind of pain that you've experienced, because actually a lot of people who haven't experienced it don't know, and it often feels very individualized. Like, my experience of institutionalization is very different from yours, very, very different. I still live with it though, and I live with the trauma associated with it too. And I think that for more people to understand it is incredibly important. So I just want to say, I think it's really greatly glad that you shared that. I also think it's what makes this space hard, because we're talking about tools like co-design and co-production. There is a lot of trauma of those who've experienced mental health crisis, and the process of creating new policies and, you know, inviting people to, it has to also involve a process of healing. There has to be allowed to be a space of healing that is emotional and not just cognitive, right? Like, I felt like I was given this opportunity to heal when one of the people along the way who'd done harm to me, my employer, gave me this space for us to have an emotional exchange, right? And at the time, I didn't really recognize, I didn't know how powerful it was going to be. It changed my life to just have it heard. And I think that, because there's a lot of tension in the lived experience space, right? You know, you go to these meetings and people are throwing apples at each other, right? Like, it's really, especially with doctors, because, you know, people have often had traumatic experiences at the hand of individual doctors at times. And how we can build a space where we love and respect and honor the voices of lived experience as well as others in the space, and we can sort of create together. I don't know, I just feel like it's harder than we think it is, and like fessing up to the difficulties of that, I think, is going to be incredibly important for the work going forward.
One of the things that I want to, you know, I could relate to what you were saying, but more from a carer perspective, and it's still going on. So my daughter was put onto olanzapine, wasn't told the side effects, put on 4 dress sizes within a couple of months. It was having a major impact with side effects for her. And I discovered the National Psychosis Guidelines. And there are strict guidelines that specify to public health units that they need to inform the person, they need to have a conversation about the side effects, they need to talk to the family, the carers as well, if appropriate. There are strict guidelines that talk about that. But, you know, in my opinion, it's not being followed. And even now, there's this medical model that exists that's very patriarchal, where you're often told this is best for you, you need to go onto this drug. And there's no discussion around the implications. Yeah, so it's still happening. I mean, I put a submission into the public mental health inquiry, and I have talked a lot about that happening, and about, you know, obvious breaches of the National Psychosis Guidelines happening constantly, and that, you know, they need to be talking to patients about the effects of these medications. And you're right, the trauma. Recently I was told by our own psychiatrist that it would re-traumatize my daughter going back into the public unit. Now that's a real worry when you think about it, that someone's going to be re-traumatized by that experience. So there is a lot of work to do. I think that there needs to be a shift, particularly from this paradigm of a medical model. I think that's a problem personally. I think that we need to shift to a model that's more, you know, empowerment based. I know that's a word where you throw around, but basically one that considers the person, that really is person centered, and that's not happening. Yeah.
Thanks, Sharon. And I think your point on not being told the impact that your medication might have on you, that's a human rights issue. So we need to be screaming louder about that. Yeah. And I'll be standing by your side, Sharon. And Amanda, your point about this work being really hard and tense. Look, I've only been in this sector for just over a year, but I can tell you absolutely it is a tense sector, and probably partly because everybody feels that there's just not enough resources to go around, whether it be money or staff or whatever resources you use in your work. So thanks for raising that. Samina, do you have anything else to add? That's optional.
I don't know if I can, you know, really be useful to add something. I think as a researcher, we only know what currently exists, and we try to evaluate what we have. So to have that visionary lens is, to me, I'm soaking it up, and I'm really interested to find those solutions and to discuss those solutions, and then really put a lot of work into evaluating how well they work, before they're disseminated into the community, because I feel, or I have observed that many times we roll out initiatives that we think make sense, they make good sense, but in reality, there are hurdles and obstacles that we haven't foreseen, and it's the people on the ground, people living it, people who need support or need to provide support, that are then actually faced with the real issues. And I think we need to get better at that, to really test what works and demonstrate that it works, and only then unleashing sort of these concepts that really are helpful. Yeah, and I apologize if I say something that doesn't really resonate, because I'm sort of in my space where I'm trying to do good, but I only, what my results only materialize in a couple of years' time. So I always kind of feel behind with what is actually happening currently. Yeah, just to explain that maybe a little bit.
Oh, good, thank you. I agree, I'm a fan of data too, and I think we need data plus stories to make these changes. So everyone is needed. Any very final points before we close? Apologies that this was running a little bit behind due to the previous meeting overrunning, but thank you for sticking with us. I feel like this conversation was way too short and we could go for another 2 hours, but anyway, thank you for coming today.